Hello, everyone. Welcome to our other session of our grand round. So today we'll be having a talk on pain management that will be given out by Dr. Junman Kim. Dr. Junman Kim is an assistant professor of radiology and medical imaging at Emory University Hospital. He has main clinical interest in pain and palliative procedures. He is also involved in angiography simulator training and ultrasound guided procedure training for residents and fellows. It's so good to meet him again after meeting him in person at Emory. You are warmly welcome, Dr. Junman. You can start the session.
Thank you. Thank you so much, everybody. My name is Junman Kim. Everybody can call me Jun. I'm one of the IRs at Emory. Today, I'm going to talk about pain interventions, especially focusing on introduction and how we can start all the, pain practices. So I know I have 1 hour, and I have so many things to talk about, but I'll go very quickly. Feel free to reach out to me if it's too quick and, have questions later. Okay, thank you. All right, no relevant disclosure. So we're going to talk about what is needed and what's our IR role as a pain physician, how to start these procedures, what is nerve block, tools of the nerve block, and when we can move on to ablation, and some different types of ablations. And I'll show you some cases, large joints, including shoulder, hip, knees, and some spine interventions, interventions of abdomen and pelvis, and extremities. So what is needed for pain intervention? And got to know the anatomy of the body, knowledge of the neuroanatomy, and you got to know what to do when we have certain types of pain. We got to have a figure out. But those require clinical experience and evidence, and you could phone a friend. And as a IR trainee and physicians of IR, we all have the skill sets to do these, I believe. So IR as a pain physician, we are limited with clinical training, treating patients with pain in our training years. But we have the understanding of anatomy through imaging, and we have the ability to use a cross-sectional imaging to approach the smaller targets precisely that no other physicians can do. And we are able to correlate imaging findings with clinical symptoms. I believe most of you probably read MRI of lumbar spine and probably heard the same people saying, oh, imaging findings on the MRI doesn't correlate with a patient's symptom. But I disagree. They always correlate. It may not be the most striking findings, but I'll give you an example. So this is a 44-year-old female, chronic right-sided lower back pain, right side lower back buttock pain. She is actually one of our IR techs. So she had 8 out of 10 right buttock and paramedian lower back pain, and unable to exercise and severely limiting activities at work, no radiating pain. So X-ray, nothing too crazy other than some degen changes of the facet joints. On MRI, sagittal T2 and a parasagittal view looks very good. Probably better than my MRI, way better. I mean, definitely better than my MRI. And no foraminal stenosis, and discs are all fine. However, watch this on axial T2 slices. What is this? It looks like T2, yes. On the right L4, L5. Can everyone see my cursor here? So right side facet joint, look at this. It's hypertrophied and subchondral cysts. So I suspected this was the problem for her. So what I what I did what I did was I wanted to target this for her controlling her pain. So this is something called medial branch of the nerves. So not a lot of you may heard about this because I also knew about this even after finishing my MSK fellowship, MSK radiology. Even after that, I didn't know about medial branch. So what medial branch is, from the each nerve root on each lumbar level, there is that branch that goes medial dorsal that wraps around this, between the superior articular process and transverse process, and it innervates the facet joints above and below. So these are responsible for pain signal coming from the facet joint pathology. So this is what we did. I apologize, the image is a little blur, but if you look at this L3 level, you can actually see the Scotty dog that we know, and this is the facet joint right here. So because patient has a pain at L4, L5 from the degenerative changes, I was targeting a level above L4 and L5, where the medial branches are coming. We initially did a nerve block, and she had a phenomenal result, and we moved on to ablation, RF ablation. So patient had 0 out of 10 after procedure, back to gym for a workout, no restriction at work. So it was a, yeah, very good result. So how to start pain procedure? So just like medicine, we could do trial and error. Um, Study the pain generator, anatomy. This takes a lot of time. You gotta try this one and see if it works. And like me, you could join an existing practice and just continue what we were doing. Or this is what I'm planning to do to spread our experience. So if you learn the individual procedures that we can provide, learn one by one, and eventually, and we are able to, complete the puzzle and, you know, uh, become, more, be able to do more procedures, most of the procedure in the end. So learn one by one. My, uh, that's my advice. So what is a nerve block? Let's talk about some nerve block. This temporary disruption of a nerve signal transmission. Motor nerve, if you do the nerve block, it gives you paralysis. Sensory nerve, it gives you anesthesia. Most commonly performed as an anesthesia procedure in the OR. Propagate the effect of anesthesia, and if they give you a good nerve block, it may decrease the level of the sedation for anesthesia for the surgery. So it's becoming more popular as a palliative pain procedure. Then what is an ablation? You know, Permanent interruption of a nerve. This is specific for nerve ablation. Yeah. So permanent interruption of nerve signal conduction. So nerve block usually only lasts about from several hours to maybe a few weeks. But if we if we can, identify or find out that we can give a good pain relief through the nerve block, and we are sparing the motor nerves, then it is safe to move on to a nerve ablation. The things that we have been using are cryoablation, RF ablation, and sometimes alcohol ablation, which has a distribution similar to the nerve block. Microwave, I have never used microwave for nerve. So cryoablation creates this ice ball that you can really precise target. Radio frequency ablation, same. I know you guys have experience with cool leaf RF ablation in the genicular area. So these kind of RF ablation creates, predetermined size of the ablation zone that targets the nerve. Microwave can be used in some solid organs, but creates a very large zone, so not suitable for pain procedures. And why do we prefer cryoablation? So this is a picture of a cryoablation of a kidney mass. You can definitely see the cryoprobe right in the middle, and the ice ball shown in the CT scan. And in these where areas with a critical structure like colon, cryoablation definitely has an advantage because you can just visualize the margin. So cryoneurolysis, predictable ablation zone, well visualized zone, and also it has the ability to let the nerve regenerate in a controlled manner. And also compared to other modalities, microwave or alcohol or radio frequency, it gives immediate pain relief. So this is something described by Sunderland in UK several decades ago. They categorized the nerve injury grade. So if you look at Sunderland 2, this is the only thing that you need to know. So it creates an axonometesis, which is myelin sheath. The axon is the one that actually transmit the signal, and myelin sheath is the sheath that covers the axon. And furthermore, it is covered by endoneurium, perineurium, epineurium. When we do cryo, so let's assume this is the damaged nerve that creates the pain, or sensory nerve that can be spared. So when we do cryo and cryoablate the nerve, what it creates is the damage of the axon and the myelin sheath itself, but it does not uh, create damage to the endoneurium, perineurium, and epineurium. So idea is it only creates Sunderland 2 injury and it will regenerate. So it's not, so because it is keeping that scaffolding for the nerve to regenerate, and we know by experience that it regenerates. So that's why cryoneurolysis is the ultimate um, ablation of choice in our pain procedures. So tools of the trade. I almost always use a 22 gauge spinal needle for diagnostic nerve block. It has a better steerability compared to Chiba, but Chiba can be used depending on circumstances. Lidocaine, 2 hour. I also use a 0.25% bupivacaine, which has a longer prolonged effect. And steroids, sometimes I use a Canalog, which is a preamcinolone, or if I need to go with a non-particulate when I'm doing blocks above the diaphragm because it has a higher chance of going up. So I tend to use a dexamethasone. Sometimes I use contrast if I need to see it under CT scan, very dilute, 10:1 or 20:1 mixture. With saline is fine. D5W is reserved for radio frequency or microwave, yeah. And chemical neurolysis, cryoablation devices, there are a few different things in the market. I have a hydrodissection needle to separate some critical structures. Heat packs, when you do cryo, especially just under the skin, when you are worried that you protect the skin from frostbites by using some heat packs. I use it with a warm saline in a sterile glove. Sometimes steroids for post-procedure pain. Alcohol can also be used for chemical neurolysis, in which case I use like 5 to 10 cc or 99% ethanol. So these are some of the stuffs, and we're gonna move on to cases. I'm gonna show you some cases of large joint ablations. So the most common indications for large joint ablations are OA, and it's a continuation of minimally invasive treatment spectrum. So when you have OA, osteoarthritis with degenerative changes, you can do physical therapy, NSAIDs, medication, and ultimately arthroplasty. Joint replacement is the ultimate treatment, but this large joint ablations comes into play somewhere in the middle. So targeting sensory nerves, and this is for patients suffering total knee replacement or joint replacement, and who may not be a candidate for surgery due to old age or BMI, surgeons not willing to operate. Hip, 87-year-old female with OA, persistent right hip pain for many years. It's getting worse, and they tried intra-articular hip joint injection. Initially, it worked. Now it's not really working, and patient does not wish for surgery. As you can see on the right hip, very bad OA. So joint space narrowing, subchondral sclerosis, and you can see the same thing on fluoroscopy images. These are some of our targets. So I'll show you the diagram, but this is the obturator foramen. Teardrop. Teardrop is where the um, obturator nerve coming from S2, S4 follows travels along the inner pelvic wall, and through the obturator foramen, it comes out towards the hip joint and innervates the medial anterior part of the hip joint. Also, this is the targeting for femoral nerve articular branch. Notice, this is not the main femoral nerve branch. This is a femoral nerve articular branch that innervates the superior part of the acetabulum. So these are where the bony landmarks, about 50%, like 12 o'clock position of the acetabulum and under the teardrop for the obturator nerve. So those are sensory branches of the femoral obturator nerves that innervates the um, joint capsule. So these are the diagram. Again, obturator nerve, the lighter color, and femoral nerve articular branches. So those are where we target for nerve block. If they work, we move on to ablation. So ablation of choice for these are currently radiofrequency ablation because it is financially more cost effective, and it's way quicker, so and equally effective. So at 2 weeks follow-up, now complaints of knee pain. In this case, patient is no longer complaining of a hip pain, so this was a success. So knee. This was a 55-year-old male with a left knee pain under his kneecap. It's a little atypical because this patient did not really have a OA of the knee, as you can see, but patient on MRI, patient had a patellar subluxation, transient patellar subluxation syndrome. So patient had a pain at night in the upper patellar area. So we had no evidence, but he responded with a diagnostic nerve block, so we went ahead to do the ablation. So this was a nerve block. I'm sure many of you have seen these procedures. So these are the typical targets for our genicular nerve blocks. I'll show you some diagram to explain. Uh, superolateral, femoral branch, and this is inferomedial genicular nerve, about 50 to 60% into the femoral cortex. And this was the ablation later on after he responded to the nerve block. So same thing, about 50 to 60% depth into the, but the target is usually here, junction between diaphysis and metaphysis. So you go right next to that, and because it runs over the periosteum, the genicular nerve. So if you place these close enough, it'll cover the nerves, the genicular nerves. So patients with KL grade 2 to 3 OA fail conservative management like PT, joint injection. You can start with a joint injection. Knee replacement is the ultimate treatment. So we apply the heat to destroy and transmit pain transmitting sensory nerves. So this is the one of the diagrams of how the genicular nerves. So genicular nerves this is not a single origin of nerves, actually. because it has multiple innervation from different nerves. So starting from sciatic nerve in the posterior, sciatic nerve gives superomedial, superomedial, superolateral, inferomedial. But also, if you notice these nerves coming from the top, these are actually femoral nerve branches innervating vastus lateralis, vastus medialis, and vastus intermedius. So these nerves that supply the muscles of the thigh also gives nerves ending. So there is no single genicular nerve. It's a multiple web of multiple different nerves. So this is a typical diagram where we target lateral, medial, inferior, about 50% to target to cover the multiple different genicular nerves. 2 weeks follow-up, most of the pain is gone. Shoulder, 66 female, 10 out of 10 pain shoulders at night. History of bilateral rotator cuff tears. Patient was referred for nerve block ablation. So we target multiple nerves for shoulders from posterior and anterior. From posterior, we target suprascapular nerve, axillary nerve, and from anterior, lateral thoracic nerves. So I'll show you the diagram. Patient had a 1 week follow-up, significant pain relief. So this is a diagram from a journal from memory. This is the suprascapular notch, where the branch of suprascapular nerve innervates that posterior part of the humeral head. And this is the axillary nerve wrapping around the scapula, and this is the posterior. By the way, A is the posterior. So this is the around the greater trochanter. This is where we target for the axillary nerve. So these two nerves we approach from the posterior approach, and from anterior, this is the coracoid process, and we target the coracoid process for lateral thoracic nerve. And this is another picture from a journal that we are targeting the suprascapular near the glenoid. This is a targeting for axillary nerve. This is targeting for the lateral thoracic nerve. Yeah, as you can see from, bad OA of the shoulder. All right, moving on to spine procedures. So this is something we do selective nerve blocks. So 43 acute left neck pain with radiation, high performance athlete, acute left-sided neck pain with 8 out of 10 radiating pain to left upper extremity for months. Patient tried PT, steroids, oral steroids, not resolving. Got an MRI and no, actually had an MRI and had a CT actually. So I reviewed the imaging. If you can look at the CT on the center, it's the degeneration is pretty bad. You can see the oncovertebral joint hypertrophy, and look at how tight that left side neuroforamen is. And also from MRI, notice that right side isn't normal either. It is narrow. If you can see a normal cervical spine MRI, many times that width of the neuroforamen reaches 8 millimeters, if not 1 centimeter. But this patient probably had like 2 millimeter opening. So this you can also see from this that sagittal images of the spine that C5 to C6 is terribly narrow. So what we did, we went to do the transforaminal approach, cervical epidural steroid injection using 22 gauge spinal needle. I believe I use bupivacaine and dexamethasone here. So we are close enough. And at this point, I think you can faintly see some contrast that's spreading towards the neuroforamen. So neck pain, radiating pain, completely resolved, 0 out of 10 pain a few days later. All right, Now moving on to lumbar spine, 32 male, 10 out of 10 pain, right posterior thigh and leg pain. So history of L5 disc protrusion. This was a MRI of years ago when patient had L5S1 disc, but this is the current imaging. Uh, Look at the disc extrusion with inferior migration, and it's actually severely impinging the right S1 nerve root, actually, because of the L5 descending S1 nerve root is severely compressed at this point. You can't even see. This is the S1 nerve root right here. So because this is we gotta approach from the sacrum, this is not easily done from the fluoroscopy approach. I knew this needed a CT because of the location. So this is, I'll show you. It'll be a little difficult, but you can actually see some, fat density here. And this is the S1 nerve root right here. So I saw the opening through S1 neuroforamen right there from posterior. So this is the only approach that we can do the nerve block for this one. So this was the approach that we use, 22 spinal needle through the posterior foramen and injected some contrast so that it outlines the nerve root right here. So patient pain came down from 10 to 1 the next day. Ultimately, because of the disc extrusion, patient ultimately required right hemilaminectomy 6 months later. But the pain was relatively controlled until he had the surgery. So selective nerve root injection, MRI CT findings that can match clinical presentation. You gotta really look at the imaging yourself as a radiologist. We can do from cervical spine to sacrum. Fluoroscopy can be used. Sometimes CT can be used as well. Most of the time, I use a triamcinolone, which is Kenalog, but this is particulate. So when you are working in thoracic, cervical, using dexamethasone is safer. 0.25% bupivacaine, preservative lidocaine can be also used. All right, moving on to abdomen and pelvis. This is a 53-year-old male with intractable abdominal pain. This is actually my first pain procedures as an IR attending. So patient had 8 out of 9 abdominal pain for the past 3 months. Had a stage 4 pancreatic cancer with liver metastases. So this was the CT scan that he had when he was getting a biopsy of the liver mass. So you can see the large pancreatic head mass, diffuse liver mass. So I knew what we had to target. So patient clearly is having pain from pancreatic head mass and the liver mass. So we were planning for splanchnic nerve block and / ablation. So what are the risks and benefits? So I think this is a little premature, but there are some risks with because the splanchnic nerve is a network of a sympathetic nerve channel that we are blocking the sympathetic. So the risks are unopposed parasympathetic drive, overdrive. So we may have some posterior hypertension, intractable diarrhea. Probably in our limited experience, probably about 5 to 10% of patients eventually develop this, but they are, you know, usually the management is conservative and they get better. So this is, you guys probably heard about celiac plexus block ablation. So this is one of my drawings to plan for celiac plexus procedure. So aorta, celiac artery. This is the needle trajectory for nerve block of the celiac plexus or celiac plexus block or ablation. But this was a planning image for splanchnic nerve block and ablation procedure. Look at the left. It is the needle should go around the aorta near the celiac artery. It's very challenging. But splanchnic, all you have to do is just go beside the vertebral body and place your needle in this fat plane, para-aortic fat plane behind that diaphragmatic crura. So way more easier, way more quicker. I'll show you why we do these nowadays. So this is some diagram. The big red celiac. This is triangular zone is a target. This is way easier. So this was the actual procedure for that patient that I was given. As you can see from the needle, this was one side was correctly placed. The right side was anti-crural. So this was not a great placement, but the next day, patient, was joking, "What pain?" Asking me, and smile. 0 out of 10 pain. So discharged home. Patient passed away home without pain. So what's the celiac plexus? So RP, retroperitoneal confluence of neural input from mesenteric organs. It's a axonal meshwork. It's not just single nerve. It's a mesh of a spider web of nerves. So it continues upwards as a splanchnic fibers along the vertebral bodies. So it's a good target for intractable pain arising from the upper abdomen. So this is the diagram, the axonal meshwork around the celiac artery. And as you can see, these travels back up and it travels along the anterolateral border of the vertebral body. So back in the days, there are many literature from anesthesia that targets these, but uh, many experts are increasingly switching the procedure to splanchnic nowadays because technically it's way more easier, less challenging, and equally efficient, if not better. So this was the targeting for splanchnic. I'm sorry, targeting for the celiac plexus. So splanchnic nerve. So these are paired splanchnic nerves that carry signal coming from the celiac plexus, and it's now increasingly recognized as an alternative target for the pain procedure. And people say it's a broader, it gives pain relief in a broader area. And I typically target at the T11, T12 junction. So from celiac plexus, it travels towards the sympathetic chain, and I target at T11, T12 junction. So this is the diagram showing how we do the splanchnic. This is the proposed location of these splanchnic fibers, and that's why we try to target posterior to the diaphragmatic crura. So this is how I find that fat plane, big red, target zone, same. This was a nerve block I did and injected some dilute contrast to show that we are in the correct spot. Yeah, again, another procedure showing infiltration of the same spot. And this was a cryoablation procedure. So I am creating oblong ice ball in that region for the pain relief. So the fat plane our target for the nerve block, 22 gauge. If effective, we can do cryoablation. If the anatomy doesn't allow for adequate positioning of the cryoprobe, we also perform alcohol neurolysis. Now, moving on to intercostal nerve, chest wall, rib pain, some intercostal neuralgia for some other reason, post-mastectomy, thoracotomy, herpetic neuralgia, indwelling drain catheter giving you terrible pain through the intercostal space, sometimes rib mets, diffuse pleural mets, if it's especially local, if there is a subpleural mass really creating, causing some pain, intercostal pain, it is also tried and it was helpful. So this is how we typically target. So before we do anything, um, you gotta look at the patient. If it's a post-surgical patient, I look at the patient where, draw a marker where the surgical scars are, and I identify that involved ribs, and I look at them under imaging CT scan before. This was, by the way, this can also be done under fluoroscopy, but you gotta spend some time to target the correct rib numbers. So if there is like a rib resection, it's easy. You can just do that rib and above and below. But if there is no, surgical scar or um, any rib resection, then you gotta do a really good job drawing the marker and follow the rib posteriorly. So you target the ribs a little posterior or more proximal. So this is how we target for nerve blocks as well as cryoablation of the intercostal nerve. Just try to go underneath of the nerve, and because the cryozone and even the nerve block and cryoablation, they both spread a little larger zone. So precise target targeting is usually not necessary. I mean, I try to be precise as possible, but many of you may question, are you not worried about intercostal artery? Yes, we are, but imagine we all do uh, vessel access using 21 gauge needle to do the angiogram procedure. So if you are not really doing the jabbing motion when you use a needle, it's very difficult to puncture the actual blood vessel. You really have to, do this jab motion. So what I try to do when using 20 gauge 22 spinal needle and these cryoprobes, I try to avoid the jabbing moment. Even if this is just my theory. So even when my needle tip is on top of that tiny intercostal artery, if I just push it as opposed to do the jabbing motion, I believe that the needle will just slide over that intercostal nerve. So many procedures I've done, I have never, knock on wood, but never had any bleeding from the procedures. I hope it'll be the same for everybody. So this is again, I believe a case who had a thoracic T-bar procedure, and patient had actually a rib resection at one point. So when we do these procedure, we always target a rib, the level above and below as well. So always three level nerve block, 3-level ablation. So you can see the rib resection margin right here. So anterior lateral cutaneous branch. What is this? Yeah, never heard about this, but this is actually not difficult. It's the continuation of the intercostal nerve in the anterior chest and abdominal wall. So pain related to surgical scar in the abdomen or through the rectus muscle. So this example of patient had a LVAD, so left ventricular device, and had a power cable coming through the rectus muscle. So this is the diagram, intercostal nerve that goes all the way to the anterior. This is called the anterior cutaneous branch. You can use CT or ultrasound. You can all use cryo or alcohol neurolysis. This patient had an LVAD drive line, the power cable where it enters the rectus muscle. Patient has severe pain. So we knew that anterior cutaneous branch was responsible. So I targeted under ultrasound, also use CT. I think this is also one of my earlier cases. So because the colon was right next to it underneath, so I was not comfortable doing cryoablation, so we used the alcohol neurolysis. So patient was doing way better. All right, superior hypogastric plexus. Many of you may have heard this. Many of you are actually doing this if you guys are doing uterine artery embo, uterine fibroid embo. So this is very commonly done in conjunction with a UFE procedure to decrease the post-procedure pain. The typical target is lower 1/3 of L5 and upper 1/3 of S1. And the sympathetic fibers, bilateral hypogastric nerves. This is the diagram from a textbook. That L5 area under the bifurcation, this is the typical target. So you don't want to go to the disc level. You don't want to go through the aorta, but some people accidentally do without consequences, and it takes care of the pain in the pelvic viscera. So this is how we do under fluoroscopy technique. So I position the II, the detector, to align the superior inferior end plate of L5, try to target the lower inferior L5 as possible, try to avoid the bifurcation. The lateral image shows the correct placement. We inject some contrast to confirm the location. Sometimes fluoroscopy was not available on this day, so I decided to do it under a CT scan. So this is some uncomfortable truth. When we do these procedures, we may be going through the sigmoid with different material here. So we went through with a 22 gauge spinal needle, and in these cases, make sure that you are not targeting the disc space. You make sure you target the periosteum, the bone itself, because if your needle tip accidentally goes to the disc, there are cases that caused discitis osteomyelitis. But if you target the periosteum, no problem. This is the bifurcation, and we're able to deliver the medication in the CT scan. Chronic pelvic pain, cancer from pelvic structures like uterus, cervix, endometriosis, UFE pain management. Sometimes there are some debate, but antibiotic prophylaxis is needed depending on what you are worried about. If you are worried about going through uterus, some people use ceftriaxone or cefoxitin. I think this is a 4th generation, or second and first generation with a metronidazole if you are going transcolonic. All right, moving on to pudendal, 74-year-old female with a chronic pelvic pain for 20 years, getting worse. What do we do? Vaginal, labial, lower abdominal pain, history of multiple different surgery. You name it, she'd had it done. So this is where we target for pudendal. And this time we did a nerve block, responsible, so we did a cryoneurolysis. So pudendal nerves are coming from S2, S4, sensory, adds some motor to the pelvic floor muscles, but they are usually able to be spared. But in patients with a bigger body habitus, we notice that they have some problems with incontinence. But with the pelvic floor therapy, they do better afterwards. So S2 to S4, and it travels inside the pubic bone. And at 3 months follow-up, 80% improvement of vaginal labial pain. So now complains of a residual perianal, a little more posterior superficial pain. In this case, we moved on to inferior hypogastric nerve block. So we typically go through transsacral, through S3 or S4 neuroforamen, and target our medication in the presacral space. You can see the air bubbles that we are targeting. So positive pain relief from the inferior nerve block. So we moved on to alcohol ablation. This is the distribution of the alcohol ablation of that inferior hypogastric. So it's another network of nerves that's sitting at the anterior surface of the sacrum. Patients with a lower pelvic pain, perineal pain, perirectal pain are the typical targets for inferior hypogastric plexus. All right, this is some now more complex cases. This is one of my all-time favorite case. I'll show you because we have time. 71 female, severe right hip pain, hip region pain, not hip pain. Constant and sharp, 10 out of 10 pain. So MRI shows a vascular malformation in the right hip region. Because of the severe pain, she ambulates with crutches, now increasing in intervals. And she also has a numbness and tingling of the right lower extremity. Look at the MRI. There is a vascular malformation right next to the sciatic nerve. This is the sciatic nerve. So what do we do? Can we do the nerve block? Yes. But will it give a long-term pain relief for? No. So I decided to move on to cryoablation for this patient. So I thought I was able to safely separate this sciatic nerve, place a needle in between, inject some saline, contrast, separate these two, and I was going to target the cryoablation probe to treat this vascular malformation without damaging the sciatic nerve. So this was the procedure. On the top left, this is the mass. And actually, I was able to separate. So you can see the contrast hydrodissection. And on the left lower corner, this is the separated mass. And on top of the contrast, this was a separated sciatic nerve. So I was confident that we were at least 1.5 centimeter apart. So I positioned the cryo probe, treated the mass itself. So this was the picture. After the needle was gone, this is the cryo zone. So 1 month follow-up, patient felt great, numbness, tingling resolved. Patient tripped to abroad and walked 9 miles per day, which is like 12 kilometers. So I was so shocked when I saw this follow-up MR imaging. So 1 second, I'll stop. I was so shocked. So I really want to show with you. Okay, so this is a sciatic nerve right here, and this is the residual tumor. It's almost gone. So no way this is going to cause problem in the sciatic nerve. So patient did pretty well. Yeah, this is the mass, residual mass, and that's the sciatic nerve, far, far away. I think it's 53. Manabas, do we still have time, or I think I don't know how many.
7 minutes.
7 minutes. Okay, I'll continue then.
Okay.
So this was another my pudendal cryoneurolysis, pudendal nerve treatment. 31-year-old male. It's a very young male, not a typical uh, patient population for a pelvic pain, a year and a half. History of psoriasis, skin disease, and he applied a lot of long-term steroid cream in the medial thigh groin area, and he developed some weird fungal infection. And after that, he had 9 out of 10 sensitivity in the perineum and scrotum area. So um, I don't know why this is causing his pain, but I know what to treat. So we went ahead and did the pudendal cryoneurolysis. This is where we targeted 3-week follow-up, brief period of pain relief, but patient returned. So I was in, so much. I had some sleepless nights after this. I gave him the cryo. He didn't help, but finally we saw him in the clinic, and I decided to give it another shot, repeat cryo. So what the initial cryo was, what I believe was, I don't think we fully covered the pudendal nerve. So this is the obturator internus muscle, and it runs along the pudendal nerve along the outer fascia. But as you can see from the first cryo, I feel like we partially missed the pudendal nerve. So I brought him back. This time I positioned the cryoablation probe way deeper. And this time, it's been almost 3 months now, and patient's completely pain-free. So pudendal nerve, primary sensory nerves of the pelvic floor, external genitalia, some motor function with the sphincters, but most people do well without any problems if we sacrifice these motor functions. But as I said, bigger patients with a BMI over 50, they tend to have sphincter weakness. They do get better after. So again, similar target for pudendals. Yeah, these were some case pictures of the same pudendals, how we target. All right. We're almost done. So actually, I'm just gonna speed up and finish. This was a 24-year-old male, 8 to 9 out of 10 left thigh pain, known diagnosis of osteoid osteoma, distal femur. So you guys all know osteoid osteoma, benign tumor. It's we learned from medical school that you take aspirin, pain at night. Usually teenagers, they self-resort. But this was a 24. Sometimes they get misdiagnosed because of these aggressive looking. Like they get misdiagnosed for chronic osteomyelitis, but they but if you can actually diagnose, and we can treat this. So this is the nidus in the posterior cortex with a cortical thickening, bone marrow edema. So we were targeting these. So this is the nidus under CT scan using a bone drill to target, and you could use multiple things. You could use RF, you could use cryo, or you could use sometimes some people in Europe use laser ablation. They do very well. And 2-week follow-up, back to school, significantly reduced symptoms. All right, companion case. I think this may be one of the last ones. 20-year-old male with intractable right index finger pain. Known diagnosis of osteoid osteoma in the index distal phalanx. Very, very unusual location. Patient had a resection of tumor with surgical oncology 1 year ago, but it recurred. So this is it. This is the nidus, low density. Look at how swollen the fingertip is. So how do I treat this? So because of the proximity of the skin, fingertip, and the nail bed, I was worried to treat this with a cryo. So I wanted to try with a radiofrequency ablation initially. So this is what I did, bone drill. This looks like a medieval torture device going through the fingertip. And we positioned it pretty decently in the center. And I treated with a radiofrequency ablation. 4-week follow-up, no pain relief, maybe one. So I decided to give it a shot with cryoablation this time. So same access, you know, same bone drill, same trajectory for the cryoablation. So this was a post-op day 1, 2. I was so scared that I got him the frostbite of the access area. This is where we accessed, and the skin turned white. Clearly, some degree of frostbite. But we followed up, and at some point, at day 8, I even sent him to see a burn specialist at our Grady Hospital. But he did well. He didn't have any skin injury. Eventually, these healed well without any problem. Healthy overlying skin, and after 3 months, zero pain. He's happy with the results. So osteoma, usually self-limited, but with an proper ablation, significant pain relief, if not complete pain relief. RF cryo or laser. You need some bone access kit and some devices, and we can follow up with a MRI later on. These are some of the nerve targets. Can do intercostal celiac plexus. We rarely do splanchnic. We do a lot of these. Superior hypogastric plexus for post-UFE pain. Ganglion impart, which is a difficult name for presacral. Sometimes we do iliohypogastric, ilioinguinal for inguinal pain. Pain in the groin, genitalia, sometimes vagus nerve for obesity. So I think that was it. So it's difficult to know everything from the start, but learn the neuroanatomy, learn the anatomy. We have the advantage as a radiologist, and always interpret your own imaging studies. Yeah, so they always correlate, and learn the individual procedures. Just like from simple ones, knee, starting with a knee, hip, shoulder, nerve blocks, and if by the time you are doing more and more of these procedures, you are able to solve problems for many more pain problems. So this is how I approach medicine. Back in medical school, I try to learn everything from A to Z. I was not a good student, but when I realized that you have to just make uh, learn, make things for yourself, understand one by one, eventually it'll solve the puzzle. So, and prepare yourself with evidence later. All right. Thank you. Thank you for your time. And I'm available for some questions if you have any.
Thank you so much, Dr. Junman, for
Yeah.
being a wonderful talk
Mhm.
and skeleton to most of us that will be finishing soon and would really want to establish pain management at our institutes. So I'd like to welcome, if there are questions from the floor or clarification that you would need Dr. Junman to deliver, you are welcome.
Junman, I would like to ask about when you intervene the intercostals or rib pain, the risk for lung injury or pneumothorax. How do you prevent that?
I mean, just like what you would prepare yourself, but knock on wood, never had lung injury or intercostal. Look at, am I still sharing the screen or did I stop sharing? 1 second. I'll go back. Yeah. So because of the angle of approach for our procedure, it is very difficult to cause lung injury, the pleura. When you are trying to enter the pleura, you will really have to puncture through. So look at our position. How do I, 1 second, I'm gonna, yeah. So this is a cryoprobe, but you know, the needle tip is right next to the pleura, but as again, also like, at entering the blood vessel, you really have to like puncture through. So, but then if we are using CT, then you should be ready to place a, chest tube with a French tube, but never had a problem.
Thank you.
Yeah.
Thank you for the presentation, sir. I wanted to ask a question. If
Yeah.
considering we trying to start a practice in pain management, is it advisable to just start with diagnostic block, considering that we may not have the RF or even cryo ablation?
Absolutely, absolutely. That's why I'm starting with a diagnostic nerve block. So I think until you guys have the RF or cryo later on, start with a nerve block. Although it may not really give the prolonged effect relief, but it's a good start, and you guys will be ready to do the ablation later on. If you start doing these procedure, and nerve blocks can also be repeated as many times as you can.
Thank you.
Yeah.
So
Hello? Hello?
Any other question? Did somebody ask
Yeah, I
me a
have a
question? Yeah.
question.
Yeah. I
I
think you
just
were
want to
muted.
ask.
Yeah, go ahead.
I just want to ask about the midline epidural injection. Are you not doing
Mid
them?
midline epidural
Midline
injection.
epidural injections. Yeah,
Good
I
point.
didn't
Yes,
hear
we do.
about that.
Yeah, we do that too. Yes. So we do that too. So midline
And
epidural
what is your experience about the results of midline epidural injection? If you do some.
so midline epidural injection. So I showed you targeted transforaminal when you see MRI findings of a radiation pain, those kind of arm or legs. So midline epidural injections are more like a shotgun. So it spreads all around the spinal canal. So typically, the cases I showed you, these patients who have a radiating arm pain, radiating sciatica, they can also be treated with a midline injection, epidural. But midline injection, I use them for when there are multiple different levels of stenosis, lumbar stenosis, very bad degen, and difficult to figure out which level I should do. In those cases, I do midline epidural steroid injection. Sometimes when there is when the patient had a fusion, lumbar back fusion surgery, and just having severe back pain, then I would go for midline epidural injection, and they do very well. So midline epidural injection, I can do it under fluoroscopy or CT, and you guys done midline epidurals, right?
Yes,
Yeah, we had some here.
Yeah, yeah. So I think for the right patient population, it is a very good option. But again, the downside is that it'll have to be repeated, once every few months.
Yeah, that was the other question.
Mhm.
Do you systematically schedule for follow-up of those kinds of patients?
Uh,
Or a second session, for example, a repeat session?
if we are becoming too busy to do that, but at the same time, sometimes, most patients requires epidural. You are right. I agree. they wear off. But I think if you are able to, if you have capability, I think it's a good idea for the patient to just have them schedule regularly. But another worry for me is that we did a good job and we schedule in 3 months, but what if the patient doesn't need, injection at that point? So I think we just keep them on our clinic follow-up list, and then they can always call us and schedule when they feel like they need one. So no, we are not regularly, routinely following them up with a procedure, but we are following up in clinic, so in case they need us.
Thank you.
Yeah.
Thank you so much, Dr. Junman. So is
Yeah.
there on the floor having any more questions?
Mhm. So today, I was focusing on more of a nerve blocks and ablations, but I have many more advanced ones. So I try to collect cases that are more practical today, but later on, if you want to see some very advanced cases, I have also cases. So yeah, feel free to reach out to me later. Yeah.
Thank you so much. You will
Yeah.
definitely
Mhm.
Thank you so much, Dr. Junman, and thank you everyone for attending. And this marks the end of our grand round session. So hopefully we'll
Mhm.
continue communicating with you, Dr. Junman. Thank you so
Yeah.
much.
Yep. Thank you so much. Yeah. So I see you later. Bye.
All right, bye.